So you had mentioned in previous discussions that you have a nurse navigator. So I think it is important so you have all these allied healthcare professionals that are really part of the team and I think are very important. So what's her role as in terms of ushering these patients through the system at Winthrop?
Sure, so we have a fantastic nurse navigator. She's not involved just at the patient level, but she's involved at every level. So Tara is with us at our academic meetings. She sits in on the tumour board. She comes to journal club. She's very involved in the academic discussion as well as the individual patient discussion. She's phenomenal at communicating with the patients about appointments. Time and time again, we know that patients who are being counselled about treatment options for cancer, particularly advanced cancer, they only hear about 10% of what the doctor's telling them. So she's great at being able to contact the patients, reiterate the important points. She helps them schedule scans, she helps them schedule appointments, and helps communicate to the patient where we're all trying to fit in the jigsaw puzzle of managing the patient's disease.
Neil, how are you using the extenders, mid-levels, allied health professionals in your practice?
In the practice, in my regular clinic, where I have a nurse practitioner and a physician assistant who I see my clinic volume with. As it relates to my advanced prostate cancer patients and renal and bladder, I have one designated RN who is very helpful and specializes in a lot of those therapies. But I did want to make one little comment about that when you asked Mike about how do we do this, and I think, Ken, you went right to it. We have to change our culture. You know, we've historically, I'm old enough to recognize that we've really been all about, pay for volume. And we're in this little schizophrenic tension right now because it's really now pay for value, but we're still somewhat on the pay for volume world. So we see this, but value has to be the play. And then the prioritization has to be patients first, group second, whether you're in academia or in the community, and you, the individual, third. And that's really not been our historical culture. How do you get there? It has to be, I'm so convinced of this, of strong physician and non-physician leadership. And if you don't have strong physician and non-physician trusted leadership, it's going to be so hard to change that culture. The groups that I see that are successful in it have done that. And I would really encourage our colleagues out there, academic or community-based, you have to embrace that because the world's changing right now in front of us.
And I think the biggest hurdle there, and this is going to take some time, is we know the definition of value-based medicine is outcomes versus cost. It's not about how much you spend; it's what you get for what you spend. Is there value in delivering a therapeutic agent that costs $93,000 if you can belay all these other associated events? Is there value ordering a $2,000, $3,000 tissue-based biomarker if down the road you reduce the cost of managing that prostate cancer patient? So I think most of us, especially those of us who have been active at LUGPA, is this concept 100% that this is no longer you do stuff, you get paid. I think there will still be some element of fee for service that is moving towards different payment reforms. I think it comes down to value, as you said, but value is really the big thing there is the outcome, is the metric. And then the question is, well, who defines that? And what is the metric? If you ask an insurance executive, well, that metric is how much I spent on prostate cancer last year. Again, keeping consistent with what your philosophy is patient first, which I think it should be for all of us, then the metric really needs to be about what's important to the patient. What are those quality of life issues? And everything needs to really be based around that. So again, I think you are completely right. We need to show that what we're doing, these models that we're creating, really provide value, because it's no longer acceptable to say, well, I'm better than so-and-so without any data to support that. So with that being said, Ken, you've got 50 plus people. How many, we know there's a shortage of physicians. We know there's certainly a shortage of urologists as well as medical oncologists. How are you adapting to this shortage? How are you bringing in extenders to be able to help you clinically, especially with your advanced prostate cancer patients?
Right, so we hired about a year ago a nurse to basically run our advanced prostate cancer clinic. She's a great champion of the patient. She's really a nurse navigator, and she's been the foundation of our success of this clinic. She interacts with all the 50 physicians. They all know that she's the go-to person. The patients love her, so that's really the first step. Now, already, though, we know we're going to need another one because she's been so successful. She's kind of overwhelmed. So we know that that's the next phase. Is we've done almost so well that we want to keep that patient satisfaction, that excellence of care standard so high. We're going to need another one of her. And again, we've started to hire more physician extenders just throughout the practice, just because we have to.
Are you completely depending upon her to take in patients as they come from some of your partners, or is she actively engaging proactively with your electronic health record to try to identify these things? What kind of things, and Mike, you can chime in, what are you doing in terms of putting things into the electronic health record, which obviously has become, unfortunately, an everyday nuisance for most of us, to be able to identify these patients early and not being dependent upon your partners to necessarily send them over?
Well, that's a key point. Excuse me, that's a key point. So what we've done is we have a log that she can check of all our Lupron patients, and basically when she was hired, she basically just started checking all those patients. Do they have a rising PSA? Have they been scanned on a regular basis? Because the problem is every once in a while I'll get a referral from a partner, patient's PSA is 50, hasn't been scanned, but now they're expected me to fix them. Oh, you go see Ken, he'll fix them for you. I'm like, well, where's the scans? Where's all that stuff? So again, it's about education of our partners. So now basically she's going through that log and just kind of run right down the list, and the partners know that if Pam calls you, we're gonna look at that patient to say, hey, patient needs to be scanned, might be eligible for one of our clinical trials, probably may be eligible for Provenge. So she's been very active in doing that, and it's amazing how now the partners, after 6-8 months of doing this, they think it's the greatest thing in the world. But it took time to change that paradigm of how we interact with these patients and get them in. And so that's been the biggest thing, is her just really mining that data for those patients.
For us, it's been we have our clinical research department that actually mines the data for us. They look for patients in the exact same way, looking at starting off with ADT. It was amazing, if you just want to take it back at just general urology and how we were very nihilistic before all these therapies came out, just the number of patients that had a rising PSA, but no one had bothered to check a testosterone. Just something that we, in general think is very simple is something that is not on that forefront of what most urologists are doing or thinking about in terms of even defining castrate resistance. So once we've kind of identified that, we've managed to get those patients that obviously were not responding to Lupron or any of the other GnRH agonists and switch them over to an orchiectomy and get their TE down to where they needed to be, and they weren't actually castrate resistant. It's just those kind of things have been very, very helpful. It does take time. Right. It is not something that's going to happen overnight, and you just have to be patient and persistent and have good people around you and have them recognize that this is a team approach. No one person is better than another. He may be coming to see me, but he's seeing everybody. And that's what the patients are educated about, and that's what our staff is educated about. And that they understand that their opinion matters and how this works, they are much more willing to kind of put in and have all in for the patient.
Neil, I think you said it the best. I think this is, to me, this is about a philosophy. This is about establishing a culture. And I think whether as an individual practitioner within a big group or as a group, you just have to say, philosophically, I am committed to this. I am committed to managing prostate cancer from diagnosis to death. And I think, as we all know, we've all, being traditionally trained surgeons, we're used to basically managing localized disease. To be honest with you, based upon some of the early data and some of these small trials, I could actually see where prostate cancer could be a completely non-operative disease. I mean, we already know that that the trends towards active surveillance for the appropriately selected patients in some groups is, I mean, I think we're close to 30% now. So we already know, we already understand that the heterogeneity of this disease is there are some patients that don't need to be treated. We also know that there are some patients that are going to advance, but I think the fact is, at least right now, that these patients have historically come to our practice. We've made the diagnosis. We've offered them treatment, or in some cases, no treatment. We're following them. They're established. They've been there for years and years and years. So by the time they progress, they are completely ensconced within our practice. They love coming to see the urologist. And I think you had said it earlier, the concept of going over to a medical oncologist away from their medical home, if you will, is very frightening for them. And I think the way this is set up, and again, getting back to where I think healthcare reform is going to be, we really do need to be the physicians, the purveyors, if you will, of prostate cancer.